In this video, I'm going to be answering your questions about highly effective disease-modifying therapies. Now don't turn away, because all of that starts right now. Nicola asks a fantastic question. Hi Doc, what is your opinion for Abagio maintenance therapy after 2 doses of Lemtrada? This is actually a really provocative idea, and one that I like quite a bit. Just to review briefly, alemtuzumab Lemtrada is an induction therapy. It's discontinuous. You give 5 infusions the first year, and then a year later you give 3 infusions. What this does is quite literally reboot the immune response, making it less pro-inflammatory and building up your regulatory cells. As a result, people can have a rather durable effect in the absence of retreatment. And going out 10 years, over 55% of people never need redosed. Now, the way that we studied this drug was after you had the 2 courses of alemtuzumab, the induction, you would then follow the patient, looking at them clinically and then getting MRIs. And only if they had new disease activity, then you would intervene, either by switching to another drug or giving a 3rd or 4th course of Lemtrada. And that's the way most of us practice in clinical practice since the drug's been approved. This idea, however, is really quite smart. The idea would be that you do the induction and then afterwards put them on a maintenance. And I think Abagio is actually a really solid option. Abagio is a very well-tolerated pill taken only once a day, and it does not significantly increase the risk of infection. If you look at other treatments, for example, in the setting of oncology, this is done quite a bit. Someone will go through intense chemotherapy and then put on a maintenance. Nicola, I think you're onto something. Great question and very, very good idea. Andrew Bruce asks, how often do you see breakthrough activity with Ocrevus, and what action do you recommend then? Andrew, I find Ocrevus to be a highly effective drug in clinical practice. And if I was to ballpark, I would say 70 to 80% of people have really quiet disease when they take it. Sometimes, however, we will see a new spot on MRI, or God forbid, a new clinical attack. And when that occurs, we have a discussion about one of 2 options. One option is to put Ocrevus on punishment, to tell Ocrevus, listen, that was your one mistake, you can't have any more, and if there's any new disease activity, whether that be an attack or a new spot on the MRI, we're cutting bait and switching. Alternatively, depending on the situation, we may actually decide to switch right then and there. And what do we switch to? Well, fortunately, as I make this video in mid-2023, there are multiple highly effective therapies, and so I feel like we can make a lateral move. Oftentimes we will entertain considering Tysabri or Lemtrada. Great question, Andrew. It's a beautiful summer day, and I thought I'd take you out in my backyard. If you like this video, do me a kind favor and give me a thumbs up. And if you haven't yet subscribed to this channel, please consider doing so. Thank you. Liam C. writes, Aaron, I'm Netta, no evidence of disease activity since Lemtrada. I've had 2 MRIs, but now my MS team doesn't want to see me ever again or scan me again unless I have symptoms. Should I challenge this? Absolutely yes, you should challenge this. If we think about the clinical trials data from the CARE-MS1 and CARE-MS2 trial, following patients out 10 years, 55% of those patients never had new disease activity, meaning they didn't have 2 new spots on MRI and they never had another attack, which is awesome. However, 30% of those patients went on to have new disease activity and receive a 3rd course of Lemtrada, and 14% of those patients ended up having 4 courses of Lemtrada. The point being, this isn't a cure-all, and I think the better part of valor is to keep monitoring. I personally would strongly recommend an MRI at least of the brain every year, and at least of the cord every other year, and being seen in clinic at least twice a year to make sure that we're not slipping clinically or radiographically. Definitely push back, Liam. It's your brain, it's your body, it's your life, and I think it's fair for you to advocate for yourself. Great question. Jim and Sherry Travels ask, does Tysabri halt the disease or just slow it down? Jim and Sherry, Tysabri is an outstanding medicine. It's one of the most effective drugs that's currently available for treating MS, and I think it's particularly good at shutting down inflammatory disease activity. When you take Tysabri or any other highly effective therapy, I think it's okay to demand no new spots on MRI and no attacks. None of the drugs are perfect, and none of the drugs are a cure, at least not to date. And unfortunately, even with the most effective drugs, we can see PIRA, progression independent from relapse activity, where people do have a slow decline in function despite taking their DMT. There's a lot of work yet to be done, particularly on the smoldering MS that I've talked about on this channel. And whereas I don't consider Tysabri to be a cure, I most certainly have patients who have been on Tysabri for over 10 years and have absolutely no evidence of disease activity. In the future, I think to really put the kibosh on MS, we're going to need 3 types of therapy. I think we'll need a highly effective anti-inflammatory like Tysabri, or ocrelizumab, or the other B-cell depleters, or alemtuzumab, the induction therapy. I think, secondly, we're going to need some form of a neuroprotective agent, and thirdly, we're going to need a remyelinating agent. These last 2 don't exist yet, but we're aggressively working on them in research right now. Excellent question. The most impactful thing that you could do to help this channel grow is to watch another video. So if you'd like to up your game, click the video that's on your screen right now. Until the next time I see you, this is Aaron Boster saying be safe and take care.